Hello, and welcome to our Life with Pediatric Liver Disease series, Alagille Syndrome, Overview, Updates in Testing, and Treatment. My name is Morgan Harrington, and I am the National Coordinator of Programs here at the American Liver Foundation. Today, we are joined by our featured speaker, Dr. William Balistreri from Cincinnati Children's Hospital, as well as our moderator for the event, Emily Vincent, a nurse with over 10 years of experience in the liver space, as well as the program manager at the Liver Center and the Center for Undiagnosed Rare Liver Disease at Cincinnati Children's. Thank you both so much for being here with us today. Before we get started, I'd like to share a few helpful resources with all of you. You can find out more information about Alagille syndrome at our website at liverfoundation.org, or you can visit the Alagille Syndrome Alliance website at alagille.org. There is also the Cholestatic Liver Disease Summit this June 26th through 28th, which brings together multiple liver disease communities for a dynamic 3-day event. ALF offers various ways to connect with us through social media platforms, as well as our YouTube channel. Additionally, we have a Facebook support group called Life with Pediatric Liver Disease, American Liver Foundation Support Group. There you can connect with others. Another valuable resource we have is our patient registry, which is the first ever patient registry for all types of liver disease. Our goal is to provide researchers with a deeper understanding of liver diseases, the impacts of current treatment options, and how these diseases impact patients' lives. Please note the registry is currently only available to those 18 and older who reside within the United States. With that, I'll turn it over to Emily.
Thank you. Through more than 600 publications, Dr. Balistreri has helped clarify the causes and management of liver and gastrointestinal diseases in children. His innovative research has addressed many aspects of hepatobiliary diseases in children, including neonatal cholestasis, bile acid metabolism, metabolic liver disease, viral hepatitis, and liver transplantation. In 2021, he established the Center for Undiagnosed and Rare Liver Diseases, focused on progressive familial intrahepatic cholestasis, or PFIC, a group of rare genetic liver diseases. Dr. Balistreri has been the editor-in-chief of the Journal of Pediatrics since 1995. He is the former editor-in-chief of the Journal of Pediatric Gastroenterology and Nutrition, and co-editor, associate editor, guest editor, reviewer, and member of numerous editorial boards of several journals. He is co-editor of the prestigious text Liver Disease in Children, now in its 6th edition. In 2000, Dr. Balistreri became the first pediatrician to serve as the president of the American Association for the Study of Liver Diseases, AASLD. He is the first 2-year president of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. He has received many awards that are far too numerous to count, and it is my great pleasure to introduce Dr. Balistreri, known to his colleagues and patients as Dr. B.
Thank you very much, Emily. It's a pleasure to share our thoughts regarding this very interesting and important syndrome. I first want to thank Morgan, Ivory, and the American Liver Foundation for the invitation to share our thoughts. What I'd like to do is to go through a couple of basic points. First, to define Alagille syndrome, or as it's known, ALGS, the clinical features and the genetic basis, and then summarize the clinical burden that patients and families encounter, and discuss how these challenges are met with optimal management, and then talk about the potential and future therapeutic approaches. Let me begin with a case study to illustrate one of the problems. This was a 4-year-old boy referred to us for management of severe itching or pruritus. This was uncontrolled despite being the recipient of many standard off-label medications. Mother reported that he was very irritable, sleeping poorly, and his nutritional status was quite poor. On exam, he was mildly jaundiced, quite lethargic. He He had facial features that we'll talk about a little bit later, including deep-set eyes and mild jaundice in his eyes. He had a heart murmur. He had xanthomas or cholesterol deposits on his elbows. He had skin was quite excoriated and scratched, and he had mild liver and spleen enlargement. His laboratory tests were grossly abnormal. His liver enzymes, AST and ALT, were at least 10-fold elevated. His bilirubin, both unconjugated and conjugated levels, were elevated. His serum bile acid level, which is an important marker, was about 20-fold elevated. This should be less than 10 micromoles per liter. And his stool color was yellow, which gave us a good clue as to whether there was obstruction or not. So the question, of course, that we encountered was, what is the diagnosis? Now, if you look at the causes of cholestasis or jaundice in neonates and children, this is a pie diagram. Now, clearly the most common is biliary atresia, which would account for 45% of these cases, but that presents very early in life, in the first few months, and they have pale stools. The more likely cause, given his other clinical features, is Alagille syndrome, which accounts for about 10% of the cases of neonatal and childhood cholestasis. So what is Alagille syndrome? This is not only a liver disease, it's a genetic-based multi-system disease with a wide spectrum of signs and symptoms. These are very specific, often readily observable signs and symptoms and physical features that can be noted by all clinicians. Now, typically, this would present in the newborn period with jaundice, but can present all throughout the age domains of life. It is inherited in an autosomal dominant fashion, so you only need one mutated gene. And the estimate is that this occurs in about 1 in every 40,000 live births worldwide, but I believe this is a significant underestimate. The history is that Dr. Danielle Alagille, shown here, published a paper in 1975 describing the clinical features, including the liver, facial, vertebral, and heart features back in 1985. Well, we've learned since that time that there are a host of characteristic features, not just the facial features, eye findings, vertebral abnormalities, obviously the bile duct abnormalities that are so characteristic of the liver manifestations. These patients can have dysplastic kidneys with or without cysts. And of course, a significant proportion will have congenital heart defects, peripheral pulmonic stenosis, or tetralogy. They are also at risk for intracranial vascular abnormalities. Now, how common are these? Well, it depends on the series and the perspective. But certainly in our liver clinic, we would most expect to see the liver manifestations. But the other features are also quite common and characteristic. Let me show you some of these features. This is the publication of Dr. Alagille in 1975, showing what he considered to be the characteristic facial features of two boys: the prominent forehead, the deep-set eyes, a bulbous nose, and a pointed chin. And as he would state, if they come into my clinic, I can recognize this quite readily. Another feature is what's called a posterior embryotoxin. This is a developmental defect of the membrane of the eye that can be seen quite easily with an ophthalmologic examination. Normally, vertebrae appear to be a solid block, but in Alagille syndrome, there are butterfly vertebrae. In other words, they are now shaped instead of as a block, but as butterfly-like defects. These children are also prone to pathologic leg fractures. Now, clearly they have diminished bone density as shown by DEXA due to the severity of the cholestasis, but there is also likely an intrinsic defect in bone formation due to the genetic defect that we will discuss. The kidney disease is a significant issue throughout the life of a patient with Alagille syndrome. And this, as I mentioned, can be dysplasia, a malformed kidney, or cysts, or renal malfunction manifest as acidosis or proteinuria. And therefore, they are prone to develop hypertension. So it's important that blood pressure be measured at each clinic visit, even into adulthood, as we'll talk about. It's also important to note that renal disease does not improve with liver transplant. And in fact, with some of the medications that are used for liver transplant, they may have worsening of renal function. A major concern are cerebrovascular abnormalities. In other words, the presence of tortuous and enlarged arteries in the brain, which predispose to aneurysm formation and perhaps rupture and therefore bleeding. The vessels may be occluded or narrowed, and they may form this flame-like network, or what's called moya. This should be diagnosed and managed early to avoid catastrophic events such as ischemic stroke or intracranial bleeding or hemorrhage. This is a picture of a 3-year-old boy with Alagille syndrome and a moya-like artery malformation. You can see irregular and stenotic vessels. Here, the right distal internal carotid artery is narrowed, and over here, the left anterior cerebral artery is quite narrowed, predisposing to stroke and bleeding. These patients may also have high pressure in the brain, intracranial hypertension, which can be manifest in the retina as what's called papilledema. The margins of the optic nerve are blurred, and this again can be an important finding. The vascular abnormalities, as I mentioned, can occur in a significant proportion of patients. In this study, you can see that of 268 patients, 10% had significant abnormalities with either aortic or internal carotid artery aneurysms, moya, or other abnormalities of the blood vessels. And these are quite significant in that they account for a significant percentage of the mortality in patients with Alagille syndrome. Similarly, cardiovascular defects are the major non-hepatic cause of morbidity and mortality. And these can be of various parts of the vascular system, including, as I mentioned, peripheral pulmonic stenosis, tetralogy, or ventricular or atrial septal defects. The liver manifestation is what's called bile duct paucity. In other words, in the portal area of the liver, bile ducts are reduced in number. Now, this has long been considered to be a hallmark of Alagille syndrome, but we now know that it can be seen in many other liver disorders, and in fact, it's not universal in patients with Alagille syndrome. It will increase in frequency with age, so that it's found in about 85 to perhaps 90% of biopsies after 6 months of age. Earlier, it can look like a bile duct obstruction and can be confused with biliary atresia. Therefore, it's important to make this differentiation. Why is this important? Well, let me depict normal bile flow once again. Normal bile made in the liver, of course, flows out of the liver into the intestine, where it will aid in fat and fat-soluble vitamin digestion, predominantly mediated by bile acids. But if the bile ducts are not formed, there is impaired bile flow. Therefore, bile acids do not reach the duodenum, Fat is not well absorbed, and more importantly, bile acids are elevated in the liver and overflow to be measured in blood. And this accumulation of bile acids in the liver causes the injury, the inflammation, and fibrosis that can lead to long-term scarring. What are the other consequences of impaired bile flow? Well, since they're not able to adequately absorb fat and fat-soluble vitamins, in other words, vitamin A, D, E, and K, they will have impaired growth and complications of vitamin deficiency. They will develop progressive liver injury. They will have uncontrolled itching. As you can see, this young man has scratched his skin, and they will have these cholesterol xanthomas on various parts of the body. So let's talk about the genetic basis of Alagille syndrome, because this is now very well described. This, as I mentioned, is an autosomal dominant disorder, so that a parent will carry one mutated gene and one normal gene. That is enough to transmit the disease to affected children. So any child who inherits this mutated gene will have manifestations of Alagille syndrome. If they inherit the normal gene, they will be unaffected. The mutated genes have now been described as either JAG1 or Notch2. And this is a heterozygous, in other words, a one mutated gene loss of function. These genes, JAG1 and Notch2, are critically important in signaling pathways during development of the fetus. They control embryonic cells as they differentiate into various organs, whether that be heart, liver, blood vessels, or kidney. Therefore, a mutation in either JAG1 or Notch2 will affect many organ systems. Here's a diagram. You have a JAG1 mutation, abnormal JAG1 protein, or a Notch2 mutation with an abnormal Notch receptor, which influences this intracellular pathway and therefore leads to abnormal cell development in all of the organs that we have discussed. Let me give you an example. This is the impact on blood vessels. Normally, a blood vessel will have endothelial cells in yellow, the lining cells, with smooth muscle cells coating the outside. But with JAG1 loss, there are abnormalities in these blood vessel smooth muscle cells, and therefore they are prone to bleeding, narrowing, aneurysms, and abnormal blood vessels such as moya. In the liver, this loss of either JAG1 or Notch2 will interfere with a normal signaling pathway. Normally, JAG1 connects with the Notch2 receptor to allow bile duct cell development. If either of these is mutated, either JAG1 or Notch2, there is no signal, bile duct development is halted, and the result is bile duct paucity. So there is loss of function, and in terms of the hepatic manifestations, in terms of the normal hepatic triad, there is usually an hepatic vein in blue, an hepatic artery in red, and a bile duct in green. But in Alagille syndrome, there is no bile duct formation due to the loss of functioning JAG1. Now, these mutations, either JAG or Notch, are identified in a significant proportion of patients with Alagille syndrome. The most common is JAG mutations, which are present in 94% 95 or 94% of clinically diagnosed patients, whereas Notch2 mutations are identified in a much smaller percentage. Now, the problem is the mutation does not correlate with the clinical manifestations. In other words, there's no clear genotype, the mutation, with the phenotype, the clinical characteristics. Or do they predict the severity or involvement of specific systems? Now, more than 700 different mutations in JAG1 have been identified. And most of these mutations, over 65%, will lead to no functional protein being present. In other words, they are called truncated mutations. The remainder of the 30% are missense mutations, which means there's some function is possible. Here's a diagram of JAG1 mutation types. Less than 15% are missense. Most in blue means that there is no functioning JAG1 protein. Now, in Notch2 mutations, it's the exact opposite. Most are missense mutations, with only a small percent being truncating or absent protein. Now, the patients with Notch2 mutations, it's a limited number of cases. Remember, it's only about 3 or 4%. So therefore, we do not have good genotype-phenotype correlations. There appears, however, to be less heart and bone involvement and fewer characteristic facies than in Alagille patients with JAG1 mutations. There clearly are disease modifiers. Not only are there a host of different mutations, but within families, including twins, monozygotic twins, the same mutation has been shown to confer a wide range of clinical manifestations. And that suggests the role of genetic modifiers, either having a positive or modifying effect or a negative or worsening effect. And these are likely organ specific, and we need to learn more about those. Now, what if no mutation is identified? Well, that'll occur in maybe 5% of patients who have the clinical characteristics of Alagille syndrome, but when genetic testing is done, there's no disease-causing mutation found. Of course, other diagnoses should be considered, or there are now ways using deeper sequencing, whole exome or whole genome, that can be used in hopes of identifying even more novel gene mutations. Now, what about parents and siblings? Well, in about 60% of cases, the genetic abnormalities are not inherited as a mutated gene, but arise spontaneously during development. In other words, they are called de novo mutations. But that means that 40% of patients will have a disease-causing mutation, so they need to be evaluated. Now, their phenotype or their clinical features may be mild and undiagnosed, and that's happened in my clinic many times. Parents did not realize they were carrying a mutated gene. So it's important that they understand their risk. It's also important to let them know that 50% of their children, future children, are at risk for Alagille syndrome. But again, we're not able to prognosticate severity because of that lack of genotype-phenotype correlations. So what is the natural history of Alagille syndrome? And I'll focus predominantly on the liver manifestations. Very nice study published in 2020 looking at the outcomes of patients with Alagille syndrome that presented with cholestasis. This was a study of 293 children with Alagille syndrome. All had cholestasis, of course. 91%, as you might have predicted, had JAG1 mutations, 4% Notch2 mutations, and about 5% no identified mutation. And what happened to these patients? This is the percent that over 20 years remained transplant-free survived. In other words, they retained their native liver. And you can see that as the years go by, many of these patients were subjected to liver transplant, such that at 18 years, only 24% were surviving with their native liver. Another study looking at the natural history of children with Alagille syndrome was conducted by what is called the Global Alagille Alliance, or GALA. This was a retrospective data collection by the GALA group of 1,433 patients with clinically or genetically confirmed Alagille syndrome. Now, these came from 29 countries. Remember, this is a worldwide disease. Again, the majority presented with neonatal jaundice or cholestasis. The majority had some degree of pruritus. And what happened to these children? The main outcome was, did they develop cirrhosis and clinically evident portal hypertension, which I will define here as scarring in the liver, the development of collateral blood vessels manifest as varices in the esophagus, an enlarged spleen, or splenic and portal vein occlusion, clinically evident portal hypertension. So you can see what happened over 18 years. By age 18, with a continual rise in clinically evident portal hypertension, 67% had obvious portal hypertension. What about the rate of native liver survival? So this is the cumulative percentage of liver events, either death, liver transplant, or combined liver transplant or death. And you can see that over the years, as a proportion, about 10% of these children died. Another proportion required liver transplant, so that cumulatively, the rate that were surviving with their native liver was 67% at 5 years, 54% at 10 years, and only 40% at 18 years, because of the accumulation of liver-related events. Was there any way to predict native liver survival? Well, indeed, the higher the level of bilirubin, total serum bilirubin, the worse outcome. You can see the decline in native liver survival in those with a total serum bilirubin over 10 milligrams per deciliter, compared to those with lesser degree of jaundice between 5 and 10 milligrams. And the best survival were those who had lower levels of bilirubin at less than 1 year of age. So you can predict the outcome to a degree. Now, what about post-transplant survival? Because many of these children, as you saw, were subjected to transplant. So patient survival following liver transplant was calculated in 345 children. And the good news was 94% were surviving following transplant at 10 years and 88% at 20 years. And many of the lack of survival cohort was due to kidney manifestations. So again, we must be aware of the renal manifestations as these children survive liver transplant. Another concern in patients surviving with their native liver is the risk of hepatocellular cancer, liver cancer. This has been reported as young as 3 years of age. So that's another parameter that we must follow as these children grow older. So how do we diagnose Alagille syndrome? Well, first of all, it should be emphasized that this still remains challenging due to the highly variable presentation. But precision will impact the course and could worsen outcomes if the diagnosis is not accurately made. Let me use this patient as an example. This child was misdiagnosed as having biliary atresia. As I mentioned earlier, the biopsy can look quite a bit like biliary atresia early in life. He underwent an operation in hopes of treating biliary atresia, but required a transplant at 6 months of age. So our standard diagnostic strategies are to have a strong clinical suspicion, then biochemical assessment of liver function. Often a liver biopsy is conducted. We often consider surrogate tests and biomarkers, although these are not reliable in Alagille syndrome, because the gold standard now is molecular genetic testing. The steps that we emphasize are early recognition by primary care doctors of cholestasis, in other words, conjugated hyperbilirubinemia. We then must rule out specific treatable causes. We then must exclude biliary atresia because they will, if they have biliary atresia, require intervention, and then differentiate whether this is Alagille or a related disorder called PFIC. We have a standard evaluation, which I won't go through, but clearly it begins with fractionation of bilirubin. Not all jaundice babies have this specific test done where you differentiate conjugated versus unconjugated. A very important test that must be conducted in all babies with persistent jaundice. We then do a battery of tests to look at for specific causes, including perhaps a liver biopsy. But I believe, as did Dr. Alagille, that the diagnosis of Alagille syndrome can be made clinically. The clinical diagnosis can be confirmed if a patient has 3 of the 7 potentially affected systems involved. So, for example, they have a characteristic face, they may have a cardiac defect, and bile duct paucity. That is a clinical diagnosis of Alagille syndrome. And here's a table that looks at whether a patient has a pathogenic variant in either JAG or Notch, a family history of Alagille syndrome, and then the number of clinical features. So if a patient has an identified variant, then clearly that supports the diagnosis. If a family history is present, it doesn't matter how many clinical features. That patient could be confirmed as Alagille syndrome. If there's no family history, then the patient should have at least 1 clinical features. But if the variant is either not identified or not screened for, if that patient has a family history, then either 2 or 3 features would confirm the clinical diagnosis. The 2025 approach, though, it relies on molecular genetic abnormalities. We now have readily available sequencing panels to search for either JAG1 or Notch2 mutations. And we have, as I mentioned, whole genome or whole exome sequencing for patients with non-diagnostic panels. And we recommend, when evaluating infants with cholestasis, to use these genetic panels early on to clarify the diagnostic picture. To quote Dr. Sutton, the use of genetic screening panels early can avoid invasive tests in genetically confirmed patients with Alagille syndrome. The only issue is it takes 4 to 5 weeks to get these results back. So that's a little bit of an issue that we must address. Let's now turn to the management strategies, current and perhaps future. Current medical options are based on aggressive management of nutritional deficiencies, supportive therapies for symptom relief, the itch, and of course, the management of complications of liver disease. Our therapeutic goals are to improve the quality of life, growth, and itch, and to forestall the progression. The nutrition and growth issues are addressed by using nutritional supplements which contain medium chain triglycerides. These are much more efficiently absorbed than standard long chain fats. These are supplied as specialized infant formula in which the fat is MCT oil. We also supplement very aggressively with fat-soluble vitamins A, D, E, and K. And then we monitor very closely. Are they growing? Both by clinical and biochemical parameters. What about their neurodevelopment and quality of life? And are the complications of chronic liver disease beginning to manifest? The way we do this, clinical examination, of course, look at liver and spleen size, the skin manifestations to gauge the degree of itching, and an abdominal ultrasound and a serum alpha-fetoprotein as a screen for liver cancer. How do we address the itch? That is a major concern. In an Alagille International Symposium held here in Cincinnati a few years ago, 42% of parents or children with Alagille syndrome were very unhappy with current therapeutic approaches to itching. Their quote, "The attempts to reduce itch are wholly ineffective." So these children are in the itch scratch cycle where they itch, the skin is damaged, and it just continues. So we need better methods. Now, the challenge that we have is we don't understand what causes the itch. We don't know the exact compound that causes the cholestatic pruritus. There's no correlation directly between itch severity and serum bile acid levels, but these help us to monitor to some degree because they show the degree of cholestasis. So without a biomarker for cholestasis, we need to develop more targeted therapies and monitoring. Out of desperation, we traditionally have used surgical management, of course, liver transplant, which I mentioned, or procedures to divert bile away from the liver, either an external diversion in which bile is drained from the gallbladder to the outside, or to block the ileal uptake of bile acids. Now, this surgical management, these are aimed at removing significant proportions of the bile acid pool size, either to the outside with an external diversion or dumping it into the colon with an ileal diversion. Now, this procedure has been done, and indeed there are reports of rapid and sustained relief, perhaps with improvement in the degree of cholestasis. But this is unpredictable, highly variable between both patients and centers. So it's not a reliable means. And as I mentioned, liver transplant, certainly for end-stage liver disease, can be conducted. But again, there's a high incidence of post-transplant mortality due to the multisystemic nature, either the renal issues or the heart issues. But certainly if a patient has any of these indications, then a transplant can be conducted. One of the major indications in many centers has been refractory pruritus. And that's been a goal. Can we reduce the amount of itch? And again, reduce it non-surgically. And a number of medications have been tried, ursodeoxycholic acid, rifampicin, for example, or sedatives. The problem is they may alleviate some of the symptoms for some period of time. However, none have been shown in controlled trials to be consistently effective. So new methods have been tried. Let me use this diagram of the partial external diversion, which surgically diverts some bile from the gallbladder into an ostomy. And as I mentioned, that can be effective. But can we achieve a similar effect without surgery and without an external drain? And therefore, we have focused on the terminal ileum. In the terminal ileum, there is a receptor. It's called the ileal bile acid transporter, or ASBT, that reabsorbs bile acids from the intestine to return them back to the liver. So can we conduct a medical diversion by blocking this ileal bile acid, terminal ileal reabsorption of bile acids, and therefore increasing their loss in the feces? And the answer is yes. We now have novel agents which will block this receptor in the ileum, bile acid uptake inhibitors. So here's how they work. They interrupt that recirculation. So bile acids excreted from the liver into the intestine, normally reabsorbed in the terminal ileum. But if you block that uptake receptor, you increase the amount of bile acids in the stool, you reduce the amount of bile acids coming back to the liver, you decrease the amount of bile acid in the liver and serum bile acid levels. Now, do these work? Well, my colleague here in Cincinnati, Dr. Mithke, using trial models of mice, showed that indeed these drugs will lower serum bile acid levels, reduce the amount of bile acid in the liver, and indeed would improve the degree of liver injury. So clearly, these drugs should be considered in patients with cholestatic pruritus. And indeed, we now have two IBAT inhibitors, maralixibat and odevixibat, that are approved by the US FDA for patients with Alagille syndrome. This drug for patients over 3 months of age can be administered daily as a liquid. This drug, odevixibat, approved for patients 12 months or older, available as capsules or pellets. Clinical trials of these drugs have shown that they can indeed reduce the degree of pruritus based on parent or even patient observations. They can improve sleep quality. They can improve the quality of life scores. Maralixibat has been shown to reduce fibrosis-related complications and to increase transplant-free survival, and therefore reduce the need for surgery such as biliary diversion. Let me show you two published studies that have documented the efficacy and safety. First, odevixibat, 52 patients, 10 countries, JAGD or Notch mutations. They had a history of significant pruritus, elevated serum bile acid levels, and they were randomized to receive either the active odevixibat or placebo for 24 weeks. And here's the results. This is a reduction in the degree of itching, which was graded on a 0 to 4 scale. So most of the patients came in with a level of 3 to 4, if it was reduced to 2 to 3, or if it was reduced to 1 to 2, or totally reduced. You can see the results over 24 weeks. Placebo recipients had some degree of reduction, but those who received active drug had almost a 2-degree reduction in the degree of itching. There was also a reduction in serum bile acid levels at week 20 to 24. Serum bile acids decreased by 90 points in the active drug recipients, whereas in the placebo recipients, they actually rose 22 points. Now, what about side effects? There was, of course, a concern about diarrhea because of the excess amount of bile acid being delivered into the colon. And indeed, 29% of these patients had transient diarrhea compared to 6% of the placebo group. But no patient discontinued treatment. As time went on, they adjusted. Here's a very similar trial of the other IBAT inhibitor, maralixibat. Again, a placebo-controlled randomized withdrawal study. Again, patients with elevated bile acids and intractable pruritus. In this study, again, there was a clear reduction in the degree of pruritus. That itch score reduced from 4 down to 1 or 2. There was a decrease in serum bile acid levels, and there were clinically meaningful improvement in quality of life scales and in the degree of fatigue. And these increases in the quality of life were durable over 2 years in the study. The conclusion was the study drug was generally safe and well tolerated. Again, diarrhea or GI-related effects were self-limiting and mild to moderate. Let's end by talking about the long-term outcomes beyond transplant. Do these drugs have an impact? Well, if they reduce the amount of bile acid in the liver, and we know that retention of bile acids in the liver would contribute to liver injury, would there be a long-term protective effect on liver? In other words, with sustained reductions in the bile acid load, delay liver transplant? And the answer was delivered by this very important study published last year. They analyzed maralixibat-treated patients to evaluate the long-term outcome of IBAT inhibition. So they compared event-free survival. In other words, an absence of portal hypertension, the need for biliary diversion or transplant, or death. And they compared patients that had received maralixibat, 84 patients, versus the study cohort in the GALA study, 1,438 patients, of whom 469 did not receive maralixibat therapy. And they looked at event-free survival. No transplant, no liver death, no portal hypertension. This is the GALA cohort that were not treated, and you can see that only 50% were able to avoid a liver-related event, whereas those who received maralixibat in 7 years of follow-up, 71% at 6 years, were able to sustain event-free survival. Suggests the potential for this drug to improve event-free survival, in other words, the time to hepatic decompensation, transplant, or death. Now, the question is, does this represent an effect of maralixibat on reducing the degree of itching? In other words, if pruritus is an indication for transplant, was the transplant delayed because the itching was resolved, or did the IBAT inhibition, reduction in bile acid in the liver, actually impact the underlying disease biology? So let me take a quick look into the future. Obviously, we need the answers to those questions about the effect long-term. But perhaps we also need definitive, tailored therapeutic strategies to not only reduce itching, but also to reverse the genetic mutation. Now, obviously, genetic gene-based therapy is a very hot area, not quite ready for prime time for patients with Alagille syndrome, but we now have various modeling systems using organoids created from liver cells to study these questions. So hopefully in the future, we can have that type of definitive therapy. But in the meanwhile, we need to focus on the unmet needs and address them as aggressively as possible. We need improved case recognition, enhanced awareness, and therefore I'm pleased that the American Liver Foundation and the Alagille Alliance are continuing to get the message out that this disease can be recognized. And it's not just hepatologists and primary care doctors, but liver, kidney, heart, neurologic practitioners should know about Alagille syndrome. We need better data regarding the incidence and prevalence so that we can, again, enforce the message. We need reliable, non-invasive monitoring approaches. And we need to address a major concern, disparity in access to care. It's clear that centers must recognize, address, and mitigate socioeconomic risk factors in order to provide excellent outcomes to all patients. Another concern is transition planning. These patients, under the care of the pediatrician, as they transition to adult providers, we need to make sure that that transition is smooth. Because the good news is children with Alagille syndrome are increasingly living into adulthood because of refined and early rapid precise diagnoses, genetic counseling, the innovative medical and surgical therapies that we've talked about, and a growing list of therapeutic strategies. So we need to inform new providers, the internal medicine providers that will be inheriting these patients. They must be familiar with the natural history of Alagille syndrome, the management strategies, the potential complications, renal, cardiovascular, cerebrovascular. So we must continue to educate our colleagues to bridge that gap between pediatric and adult care. This has been abetted by a very important review published last year on management of adults with Alagille syndrome. It reviewed the issues involved in the care of these patients following transition. It focused on aspects of the condition that required surveillance, and it provided a diagnostic framework for adult patients. So back to our case to end. Remember, he presented with bile duct paucity and significant pruritus. He was found to have a heterozygous JAG1 mutation. Treatment was initiated with an IBAT inhibitor, and indeed, the parents reported an improvement. He had only mild itching when tired. He had no abdominal pain or diarrhea, and his serum bile acids decreased substantially. So let me summarize. This Alagille syndrome must be recognized. We know the genetic basis and how to diagnose using molecular genetic techniques. We understand the clinical burden of multi-system involvement and the impact of liver injury. We have new opportunities for optimal management at all ages, and we have the potential for novel therapeutic approaches. So I want to thank you for listening, and I want to thank the American Liver Foundation for promoting this activity. My sincere thanks.
Thank you so much, Dr. Balistreri. We really appreciate that. And that was an incredible overview of Alagille and things to come and kind of where we have come from in the history as well. I'm going to turn it over to Emily. I know we've got some great dialogue and questions that are ready to go. So I'll turn it to you, Emily.
Awesome. So I actually want to start with the thing that I get asked the most as a nurse, diet. Feels like it's the one thing we parents can control. You talked about MCT oil and vitamins. Is there anything that my child, like kids with Alagille, should eat, should avoid? Yeah.
Yeah, you're right. That's a great question, and I know you and your colleagues have done a great job in helping us deal with this. No, the child should eat a balanced diet. There are no foods that must be restricted. The main issue is caloric intake, and since fats are the major caloric density issue in our diet, that's why we focused on MCT. So no, enjoy their diet. Now, obviously, for all children, we want to avoid ultra processed foods and things like high fructose corn syrup and sugar-laden beverages. But other than that, enjoy life.
Good. And then when we talk about those vitamins, it's easy to think of vitamins as just like your daily Flintstone when you're a kid, but it's so different for Alagille kids. What if they can't get their vitamins? What are the risks that they're facing with that A, D, and K?
Yes, that's a great question. Vitamin A, D, E, and K are critical nutrients. I'll give you the great example, vitamin E deficiency, which was not recognized. And in fact, in Dr. Alagille's original studies, he thought that these children had significant motor difficulties, when indeed, as time went on, it was discovered that the motor difficulties were related to vitamin E deficiency. Vitamin E is required for neuronal development. And if they do not have adequate vitamin E, they will develop a significant palsy-like illness. We've seen this in our patients if they're unable to maintain adequate vitamin E levels. So it's critically important. I could say the same for vitamin K, which is critically involved in blood clotting, vitamin A, which is involved in others, and of course, vitamin D, which is actually a hormone. So I can't emphasize enough the importance of not just supplementing, but monitoring the blood levels of these vitamins.
Awesome. And as a nurse, when I have patients who can't get insurance coverage for these vitamins, for the families out there, I want you to know there are other places to get coverage for them. I think that there's currently at the filming of this, there is the Healthwell Foundation, which is offering a $1,000 grant for families in the United States with insurance. And if possible, we can put that link below. It is for patients with diseases like Alagille. And I can also tell you, as you're transitioning small kids, that practice with pill swallowing, once the dosage is high enough that they can take a fully dosed pill, it's cheaper and it goes through insurance faster than the liquid. So your pill swallowing practice should involve candy. It's the one time I'm going to go step on Dr. B's high fructose recommendations, but we usually have kids in a very low pressure, cheery environment swallow some really tiny like nerds. And once they're successful with that, they can try a Tic Tac. And usually your vitamins are no bigger than a regular chocolate M&M. And they get very excited when they're successful. And if they're not successful, you just say, well, cool, you got a piece of candy. And once they feel really good about swallowing those whole, that's when you start offering to your physicians that you'd like to transition to pills, which can make things cheaper for insurance.
Yeah, no, that's great. Thanks. Thanks for that point.
Another question that I've had is, how often, like my kiddo's not currently seeing a kidney doctor or heart doctor, at what point should I ask for that? What do I do as a parent to advocate?
Yeah, I think these things should always be kept on the checklist. And I think if you're caring for a patient with Alagille syndrome, you're actually caring for that entire family. And I can't tell you how many times I've looked across the table at a parent and have said, you know, by the way, and it turns out that even though they have obviously reached adult age without significant complications, many of them later were found to have renal or vascular issues. So this must be kept in the forefront. certainly measuring blood pressure, assessing renal function, talking about cardiac function. And then if there's any suggestion of intracranial pathology, headaches, dizziness, anything, then that should be investigated. And that applies both to the parent who has the mutated gene as well as to the child. But simple things, blood pressure management, history, and physical examination.
And as a liver doctor, when you have that parent across from you in clinic who needs to get tested, every physician has their own style, but just as an example for families, what do you recommend the parent do first? Do they go to their primary care doctor and you just send them records? What should they do to get their tests and get clicked in?
Yeah, well, as I alluded to, the depth of understanding of Alagille syndrome is still quite limited, and that's why I'm so appreciative of programs such as this to try to get the message out. I've had best success by direct communication with either a nephrologist, a kidney doctor, a neurologist, or heart doctor. We actually had a joint cardiac liver Alagille clinic years ago. Direct communication, because I think if you refer a family and say, please rule out Alagille syndrome, you're gonna be met with blank stares. So I think it's a great opportunity for education, not just as to what you're screening for, but what to look for if it turns out that the screen is positive.
And that's really helpful. I know sometimes people feel like they just don't know what to do next. I don't know. And then as parents, sometimes the parents who are brave enough have asked me, can my kid have kids? Like they might even be a baby, but they want to know how normal that life can be normal. I don't love that word, but so can kids with Alagille go on and have their own kids?
Well, I've been doing this for a long time, and I have several grandkids, Alagille grandkids. So the answer is yes. It's interesting because I alluded to the fact that these mutated genes, JAG and Notch, are involved in all organ systems. As far as I know, there is no documented evidence that they affect reproductive organ function. And I have proof of that in my Alagille grandkids.
Yeah. And then in line with family planning and things, if a family has a baby with Alagille and they're thinking of having another kid, I know you talked through the genetics, but what would you recommend as a liver provider they do to plan and be aware of what those risks are for that other child?
Right. That's a great question. Certainly, I would recommend that they actually formally see genetic counseling if they have the intent of, number one, having further children, and number two, to taking action if they are pregnant. As I mentioned, some are spontaneous mutations, and if that's the case, then it's unlikely that the family is going to pass that disease on to another child. On the other hand, in those that are mutated gene is present in one patient, then 50% will likely have Alagille syndrome. The problem is we don't know what the clinical manifestations of that new child will be. Even with monozygotic twins, they may not have the same thing. I remember a set of twins that we cared for here in Cincinnati. One had quite significant, and these were identical twins. One had significant cardiac disease. The other had significant liver disease. Never could explain why.
So I guess as a parent, then, if you're thinking of having another child, first, congratulations, and second, the genetic counselor can talk to you. Not just your child might have a DNA result, but if we haven't tested mom and dad yet, we don't know if mom and dad are even carriers. So there's a really good chance, what is it, 40, 60%?
40%, right.
Okay, that they might not even be carriers, in which case you don't have to necessarily worry about Alagille on another baby, correct?
Correct. So you're talking about 40% spontaneous mutation and 50% of the offspring. So the odds are there. They need to decide, but that's where knowing the genetics and then the counseling would be so important.
Mhm. The other big planning question I get a lot is that transition. Thank you for linking out the title of the paper regarding adult issues with Alagille. What is your process for transitioning these patients, which I know is so difficult and tumultuous for everybody, and you as well. What are your thoughts on that process? And
Well, first, I think it's important to empower the patient and the family to understand what needs to be monitored. And then help them to identify a transition program that either patients that we have sent in the past to a hepatologist, nephrologist, whatever, and then communicate with that new healthcare provider. And sometimes it's a primary care provider that does a great job of monitoring blood pressure, kidney function, heart, blood lipids, and so on. But really empowering the child as they age and the family as to what the issues they might encounter.
I think those were the big questions that I had from families. Morgan, did you have any other questions as we've walked through this presentation?
One that did come to mind for us was, and sort of aligning with what you're just talking about with that transition of care, is, do we know about how many adults are living with Alagille? I know we said that this is probably a significantly underdiagnosed disease. So just thinking about estimates, what is it that we estimate that the general population may be walking around in terms of adults with Alagille that maybe they're unaware, or maybe they are current patients?
Yeah, that's the holy grail, Morgan, because if you would need data, you need obviously widespread genetic testing of the cohort, but you don't. In the absence of that, you'd need data on how many patients that show up with a stroke or intracranial hemorrhage really have a mutation in one of these two genes that predispose them to that. And that's the only system that's involved in Alagille syndrome. Or how many patients with various cardiac lesions really have a mutation, or patients with renal disease. So that would be a massive study to undertake. And so until we have a genetic profile for everyone living in the United States or in the world, we won't be able to answer that question. But I would say that again, emphasize this is grossly underestimated.
So along those same lines, then, should individuals who maybe experience that either hemorrhagic stroke or they start seeing some degree of renal failure, would that be a suggestion then to get tested for those mutations? Or is that maybe leading down a rabbit hole that we may not want to go down?
No, I think you could argue that it's probably not cost effective to screen every patient that shows up with some renal dysfunction for Alagille syndrome. But I think there are subsets that practitioners should be aware of that just don't fit the pattern. And in that patient, you need to seriously think about genetic paneling. And, I think the good news is, with widespread availability of these sequencing panels, more and more subspecialists are using them to delve into their patient populations across the board.
And the cost is going down. So I think Dr. B and I would both agree, we're looking at a future where genetic testing is more readily available, more covered by insurance. We just don't know when that exact tipping point will happen, when it will be easier.
Yeah, absolutely. And again, talking a little bit in alignment about cost effectiveness, you did mention a little bit of diversity and socioeconomic concerns related. And I know, Emily, you gave a great link that we will add to the bottom of our YouTube channel for this viewing when we get that live. What are we seeing? Any specific groups that are maybe hit more with Alagille, or treatment options that are maybe less available in non-teaching institutions, things like that?
I'll let Emily take a first crack at that.
I'm not sure about specific groups, socioeconomic or race ethnicity wise. I'll let Dr. B speak on that. But from a treatment, yeah, I think these IBAT inhibitors, maralixibat and odevixibat, are both newer drugs, and they are specialized. They require specialized pharmacy. They have a specialized ordering pathway. So not every physician has, and these are rare diseases. So not every physician has ordered these before and experienced it. They are orderable by any physician willing to understand and prescribe. So I don't think if a patient needs to find a new institution in order to find the drug, but I'm happy that like these programs are existing so we can get the word out on these new treatments. And it's not wrong. We have it all the time where patients will come to our clinic and come with a suggestion or an idea or a thought about a treatment they are interested in. And then I'll talk more. I would like to talk more about socioeconomics next, but I'd like Dr. B to take over with his thoughts on this question.
No, I think you said it well. I mean, I make no assumptions. I ask the family and the patient, are you able to get the medicine? Are you adhering to the medication? And if not, we'll figure it out. And so I can't pinpoint any one group because I make no assumptions.
Yeah. And I think in terms of ordering this or any other medicine, there are a lot of resources that families don't know exist. Whether it's like the pharmaceutical companies themselves sometimes will pay for the drug for a year or a few weeks to get them on it. When it comes to travel for appointments, because as you pointed out, a lot of patients live really far from their hospital. Insurance will reimburse you oftentimes for the travel to the hospital. And if you have to stay overnight, you just have to know to call ahead and arrange all of that with them. They'll have approved hotels and all of that stuff. So if you're traveling from a distance to get to your liver kidney provider, please call that number on your insurance card. Go through the 20-minute phone tree. It's worth it. Sometimes it pays for your entire visit and gas and hotel.
That is great information, Emily. And I appreciate you sharing that. That's something that I wasn't even aware of. Who would a patient or family speak to maybe at their institute in order to align that with their insurance if they need to get prior authorization or something like that? Who would be their best point of contact?
So sometimes institutions have a care manager or a nurse that helps them with those things. And I'll be honest, sometimes institutions, and I've worked at them, are wonderful, but they're not that resourced. So it falls to the patient. So I think the most important thing is for the patient to know that these resources do exist. No matter what, if you have a major insurance provider, call and don't take no for an answer. The words to say would be reimbursement for travel for medical care, hotels, gas, time, and same for if they're having trouble getting a medication like this IBAT inhibitor, or vitamin K is one I like to pick on. Dr. B mentioned that vitamin K is so critical for coagulation and bleeding. If you're a family who's trying to take phytonadione, mephyton, or a form of vitamin K and you can't get insurance coverage, you can call your insurance company and ask for a care manager or a case manager, and then just use those magic words. I don't want to get hospitalized again with a critical bleed. I don't want my kid or me to end up with a transplant. And usually that makes the insurance provider who doesn't want to spend the money jump, and they'll help you get coverage for that drug.
That's great. I really appreciate that extra information. I think that hopefully our patients and even maybe providers watching this that aren't aware of those options will be able to take some of that back. So I appreciate that. And I don't have any further questions. I don't know if you have any closing remarks that you'd like to make, Dr. Balistreri, just as we wrap this up.
Again, I just want to restate the gratitude for shedding increased light on this disorder. I think awareness is clearly going to be the key to help us all begin this journey.
Totally agree. Thank you so much.
Yeah, well, thank you both. And again, we just really appreciate this, and we will link all of our resources as well to our YouTube page. Thanks again, guys.
Thank you.
Thank you.